Fundamentally, this is some of the most important work we've ever done. It's very challenging. I was having a conversation this morning, because I was prepared to get up here this morning and basically say, we got to do this, and then fundamentally, Dr. Tammy Tucker in the back of the room said, this is really very different. This is a cultural change, and it is a cultural change. It is the engagement of partners that we've never fundamentally engaged with. Emergency room physicians, law enforcement, much more actively engaged with families. So this is kind of a changing of the way we look at addictions. Fundamentally, irrespective of what happens today, we have to build a capacity within our respective agencies, within our respective practices, to also be prepared for whatever happens next. And there will be something. But to the extent that we are viewed as excellent partners, as an alternative, as a solution to one of this country's great problems and Florida's great problems, is going to depend a lot on what happens not only here today, but what happens after. And I want to echo what Mark said relative to think of those top 2 or 3, 4 things that you think we need to address. We have a lot to learn from each other. I've had the opportunity over the course of the last several months to be involved in rooms that typically I don't get invited to. Florida Medical Association, Florida Hospital Association, emergency room physicians. These are all people that are asking for assistance, all asking for partnership on the part of the public and the private treatment agencies throughout this state. They get it. They see the toll and the cost of the opioid epidemic every day in their hospitals and in their emergency rooms. They're in a sense ripe and ready to go in terms of developing those partnerships with each of you. And that's going to be one of the strategic directions that I think we need to take over the course of just a matter of fact, days, weeks, and a couple of months. And that is a focus on where's the front door of this? The front door perhaps used to be at our detox facility. Now it's in hospital emergency rooms, or it's the back of a squad car, or it's a distraught mother who's calling you about their son who's unconscious in the bedroom. It's a very different kind of constellation of events. I also wanted to welcome you on behalf of my boss, Mike Carroll, who's the Secretary of the Department. He's very, just for those of you who may not know him, he's incredibly smart, but he's very committed to this work that we do, but he's also very demanding. He doesn't respond well to an absence of urgency on the part of his staff or those people we work with in terms of our ability to get this work done. Thank God Tammy talked me down, because I was about to give one of these rah-rah, kind of things, and it's like, I'm not sure it would have gone over very well. So the point is this: you've got a commitment on the part of partners that we perhaps have never had. We've got a lot of legislative interest. We've got interest on the part of the governor. We've got interest in many of Florida's institutions that we need to take advantage of. I think there's only the only time I've ever been in this room before was a meeting that was hosted by Richard Brown. Richard fundamentally was a hero of mine. I mean, he made me better. He made me better because he brought compassion, he brought commitment, and he brought knowledge to whatever problems we were working with during the course of the day. I'm going to miss him very much. But I would like to, in a sense, dedicate this day to kind of the spirit of Richard. He kind of set the standard for many of us in this field on how to get it done, how to work with others successfully. I wish he was here, but he's not. So we're going to have to figure out how to make it all work in his absence, and I think we can get that done. I also want to introduce you to Uta and Walter. I get to get up and talk and do rah-rah stuff. I get to talk the big picture and talk about things about what's going on at the legislature, what's going on at FMA, what's going on with Florida Sheriff's Association, all these kinds of things. But fundamentally, the work gets done by Uta and by Walter. Uta, frankly, is one of those people that's scary smart. She gets this stuff and is passionate and committed about it. Walter has come to us with an excellent background and is trying to make it all work. So I appreciate you working with them today. It's a pleasure being here in the room with you, and I'm looking forward to what happens next. Thank you.
Good morning. My name is Walter Castle, and I'm the Project Director for the State Targeted Response for the opioid crisis. I appreciate you all coming to this event. I think it's really timely, it's really important, and a lot of the great work that you guys are doing. I think it's important that we recognize, has been mentioned, that this is a change, and for those that have been in the field for a while, it's different than what we've traditionally done. And so I'm going to talk a little bit about the grant, what we're doing with the grant, why we kind of laid it all out. But I also want to talk about kind of where we're at with it and how we might be able to move forward or continue to move forward as we progress down this road. So basically, SAMHSA came out and said there were kind of three things they wanted from the STR grant. Treatment and recovery support services for the opioid crisis. They were going to fund us, and essentially year 2 we are now finishing up that application, and it's due at the end of the month, so that's looking really good. Looks like we'll get another $27 million, so we've got fingers crossed, and that continues to move forward. And then lastly, as far as the grant was concerned, 80% of it needed to be spent on treatment and recovery. So that's where the majority of the funding goes, and we'll talk about the numbers and kind of where we're at and maybe some direction that might be helpful as we move forward. So as far as the grant goals, we laid out 4 grant goals initially, and the first was to basically reduce the number of opioid deaths. Clearly everybody in this room, I'm going to assume, and probably rightfully so, has been touched at some level with what's going on with the deaths both here in the state and nationally. It clearly is an epidemic. People are losing their lives on a regular basis. The second part was to start looking at how do we address the younger folks. If we can intervene at that level before they get to that point, obviously that's preferable. So it's a prevention process, and so that's kind of the second goal, is how do we intervene in a prevention piece to maybe cut that off before it gets too far down the road. And for those of you that have been again in the field, and most of you, I'm assuming that's why you're here, we know that there's a progression when we look at addiction. One of the things that we see with opioid, much like with cocaine, it's a pretty quick progression. It's not that traditional alcohol progression that can kind of take a period of time. This happens, and this happens quickly. So we need to kind of intervene early and often. The third goal is to increase medication-assisted treatment among individuals with the opioid use disorder. And when we talk about medication-assisted treatment, primarily we're talking about three medications. We're talking about naltrexone, which is Vivitrol, the injectable, buprenorphine, which is also Suboxone, Subutex, and the third is methadone. So methadone has been around for years, and we've figured out how to do that and have done that successfully in a lot of different areas. Buprenorphine actually has been around for a while, but we're just now kind of beginning to understand how we can incorporate that into this whole process. And then lastly is how do we increase the capacity for people to learn about this stuff? How do we reach the providers? How do we reach the docs? How do we reach all the people out there that are now engaged in treating these people? And how do we educate them as far as medication-assisted treatment? So as far as the project is concerned, kind of what we started to do is we've laid out a number of kind of mini projects within this project. And our primary goal is to really expand access to methadone, buprenorphine, and naltrexone in the medication-assisted treatment arena. Secondly, we've started to distribute and train for the reverse overdose NALOXONE reversal kits. And we'll talk a little bit about that, but Amanda, my counterpart at DCF, does an awesome job. She's the overdose coordinator, and she's doing some great work. And we'll talk about how you guys can get in touch with her if you're interested in that training and helping get access to those kits. We'll talk about that in a minute. Thirdly is to implement life skills training, and this is where that piece of trying to engage the youth is involved. And we're really targeting the rural areas. I think a lot of times what happens is because of the bigger cities, the bigger number of people within those cities, sometimes the rural people get left out. And while they have just as bad of an issue, because of the ROI or whatever you want to say, it's easier to target the bigger cities. So we've dedicated some funding to the rural areas specifically to try to target those smaller areas that are looking for assistance. The next thing we've done is we've added in each DCF area as a behavioral health consultant, and their primary role is to work with the case managers and the investigators to understand addiction, understand opioid use disorder. They're not really there to do assessments on the clients, to engage the clients. They're really there as a subject matter experts for the DCF employees so they can help start to train what they should be looking for, to be able to go out on site and then once the visit is completed to ask them, okay, what did you see? And let's talk about what I saw and maybe some areas that you might want to look at and help grow them as far as addiction is concerned. Next is to expand the prescription peer mentoring project, and I believe we'll have somebody a little bit later on to talk about that project as well. But essentially what FATA has done is they've coordinated a group of physicians throughout the state who serve as mentors. And their primary role is to increase the doctors and nurse practitioners and physician assistants to get the data waiver, the Data 2000 waiver, which allows for the prescription of buprenorphine. And so their role is to help those that are in the process of it and also to get out into the communities and talk to the providers to find out where are we missing and how can we help you engage those people and get those people on board with you. So I'm really excited about some of the work that they're getting ready to do. We've got a meeting in a couple of weeks to follow up, and so each area will have a specific doc, and they'll continue to work with you all. The next bullet, and a lot of, as far as the medical or the managing entities, we've given them funding to engage that hospital emergency room visit. Basically, what's happening is there's a main pipeline where we're finding clients. And again, to Mark's point, we were talking about how do we find clients. And one of those is in the emergency department. And so what we've done is we're following a pilot that a lot of states are doing nationally, and that's how do we engage the client when they're in the emergency department. When they come in and they've been identified as maybe a potential client who needs access to treatment. And at that point, we're looking to get them actually inducted with buprenorphine to help stabilize them, so we're not getting that revolving door process. What we're hearing from the EDs is that, we give these guys the overdose kits and we get them stabilized. They get out the door and then they're back seeing us in 4 to 6 hours with another overdose. So we're trying to figure out ways that we can engage and stop that process. Interestingly enough, one of the studies that they've done with this type of a project was only about 30% of the identified clients with opioid use disorder came in as a result of an overdose. So 70% of the folks that were coming into the ED were identified in another way, whether that's through some sort of assessment or just sharing with the doc that this is what's going on. So we think that this is a great arena or a great possibility to increase the number of folks that maybe are looking or seeking treatment. And so each area will have one of these pilots in place, and we're certainly willing to engage and talk about how we can grow this process. The last thing that we're involved with, well, we're involved with a lot of things, but one of the last things that we're involved with is the peer specialists. And what we've done is we've identified within each area, DCF will have a peer specialist who is really designated to go and talk with the providers to figure out how do we increase that recovery component. I think we've done treatment pretty well. We've identified what's important. We've identified how to engage the client in treatment. I think the next avenue that we're looking at as far as substance use disorder is how do we continue that on? Once they leave treatment, how do we ensure that those those supports are in place? How do we get those wraparound services? And that's what these peer specialists, that's going to be part of their specialty, is how do we make sure that we're able to engage the community to help continue to support the client as they move forward in their recovery. Just some kind of general stuff real quick. We talk about the provider network. We currently have, well, this was as of, we did a 6-month kind of poll. So for the first 6 months, what we determined that there are basically 41 providers statewide that have engaged the MEs as far as the STR grant was concerned. 35 of those providers have reported at least somewhat to us that they are providing STR services. 6 of those providers have yet to do that. But I also think that that's heartening in that I think we're bringing new providers on, and so they haven't engaged yet, but we're still looking for the new providers and getting that network really built out so everybody's on board and everybody's able to access the STR funding. So here are some of the numbers for the first 6 months. You can see that we basically have obligated some funding for prevention, and when I talk about the prevention, what I'm really talking about is our NALOXONE, the reversal kits, and the school-based life skills training programs. So we're doing pretty well with that. We've spent about 62% of that funding. Treatment and recovery, we got a little work, right? And so we're basically at about 20% for the first 6 months, and it's a year-long grant process. So the challenge becomes how do we increase and kind of increase rapidly and start to try to go out and engage these clients as Mark was mentioning, and how do we start to spend the funding that's available to make sure that everybody's getting access that needs access. And I think that that's kind of what this whole summit is about, is how do we network with each other to figure out what's working and what's not working, so we can continue to try to push this down the road and use the funding and continue to provide services to clients that really need it. Again, to date, you can look at when we break down treatment and recovery. Treatment basically is a little over 4.5 million that we spent thus far to date, and then recovery is at 320,000. So you can see that with recovery, we've got some room to grow, right? We've got some avenues that we can figure out how to engage the clients in that recovery process and kind of build that part out. So I would challenge you guys to take a look at that and figure out what are some of the ways that we can continue to engage them in a recovery type process. Just some kind of general demographic numbers for those statisticians that are out there. So when we look at kind of the numbers of the first 6 months, the majority by a slight percentage are male at 53 versus 47. Highest enrollment age is 25 to 44. And the second highest enrollment age is 45 to 65 at 25%. And then 90% of STR funding clients were identified as white. I'd like to make a plea right now. We are asking that the providers that are currently getting STR funding, that they complete, there's a separate spreadsheet that we have put into play in order to meet some of the things that SAMHSA is looking for and some additional demographics that we need that aren't necessarily captured within SAMHSA. And I know that it's an additional component for you all to complete that, but it's really important that we get those numbers. And I will just tell you that when I look at the 6-month numbers, the vast majority of things that are being reported are zero. So I've got 0 arrests, I've got 0 housing, I've got 0 this. And so it's hard for me to think that people aren't being arrested just knowing what the population is. So I would challenge you to go back and talk with your providers that are completing that spreadsheet to ensure that they're actually completing it as it needs to be completed. And that's my ask from you guys. Again, I understand that it's additional work, but we use that data in order to continue to get funding and take that to the legislature and continue to try to push this program down the road. So if you all would be willing to take a look at that and see what you can do, I would be forever grateful. So here's some of the discharge information that we've got. Basically, administrative is at 16.7% of the individuals. And that's, again, these are the categories, and sometimes it's hard to kind of fit everything into it. I was talking with someone yesterday, and they had shared that they were in a program, and they had gotten pregnant, so they had to move them out of that program into another. So they didn't know how to move that, so they decided to do that administratively, right? So there's always going to be kind of these caveats to it. But basically, when we look at these, administratively is going to be something that you are doing within your program to discharge the client. Arrests are 2.8. They complete the program as 45.3. And this is kind of, I've got an asterisk by that because there's a program that has a number of completed folks, I think 122, and they were able to complete a program in 3 days or less. So I think it's just, again, us needing to educate, us having the conversation to understand what's going on and why that is. So I will take responsibility for that as well. And also open up, and I try to be accessible and try to get back. And if you guys have questions, please let me know. If you're trying to understand something, I try to be available as best I can. We've got death by non-overdose at 2 and death by fatal overdose by 3. Again, we've got some asterisks. We didn't find necessarily STR funding attached to these people, although they were reported. Disengaged. And that's basically 33.2% of the population. And these are the folks that just kind of drop out of treatment. And we know that they're there. But the challenge, I think, again, as we try to look at how we do things differently, it's can we do some outreach on this? Can we go back and try to re-engage? Can we go out and follow up and say, why did you leave? Was there something that, what can we do to assist? And I think that's been a little bit different on the substance use side. If someone disengages, then they're not ready. That was when I was doing substance use, that was what we would say. And what I found was on the mental health side, it wasn't so much that. If a client left, a lot of times we'd do a follow-up call and say, hey, I know she didn't come in for your appointment. Everything okay? And so, again, it's that shift. Can we make that shift and maybe see if we can't engage them even when they do leave and ask, why is that? And is there something that we can do to help facilitate or ensure that you get back into treatment? And then as far as outreach is concerned, in general, it's that how can we engage them? What are the areas that we can go and look for clients to bring them in and see if we can't help kind of build that capacity. And then we had a few that moved, which I guess kind of always happens. So for those that are familiar with the chart 8, it is kind of the covered services. It's the chart that we produce for the STR grant that outlines what services you guys can bill back to the STR grant. And so here's kind of a list of what those services are. Hopefully most of you are familiar with it. We added a couple new ones, and they're down at the bottom. And those are the inpatient detox and residential level 1 and 2. And I want to talk briefly a minute about this because there is a special caveat to it. When we started working with SAMHSA seemed to be very clear that they didn't want to cover residential or detox services. And we kind of went back and forth on that because the idea was, well, if they're getting medication-assisted treatment, they should be stable enough. And At some level, I guess that could be thought. But we also started to understand too that if someone wants to be on Vivitrol, just getting them to be clean for 7 days or 10 days or whatever that takes in order to get that injection is a real challenge. And the other thing that we started to think about is how do we get that induction piece again, where we try to stabilize the client, where we can get them kind of in a safe environment and get them stable and induct them with buprenorphine or methadone. And so we took a step back, we talked with SAMHSA and explained that this is kind of what our thinking was. And they seem to be in agreement with us. So when we start looking at inpatient detox and residential, what we're really referencing here is, as far as detox is concerned, it's to get them inducted into some sort of medication-assisted treatment. So if they come into detox, we can stabilize them, we can get them inducted into buprenorphine, and then we can go ahead and transition them out once they get stable. For residential treatment, what we're really talking about here is that period of early abstinence in order to provide a safe environment for someone to get to a place where they can actually get the Vivitrol injection. So the pieces that we've got listed out in this, and then additionally to it is what we're asking is that if you're going to do residential services for Vivitrol, that once that injection is completed, then we're asking you to go back and reassess. So where are they on that ASAM dimension? I suspect that because now they've got a Vivitrol injection, the likelihood of them overdosing now is reduced. So maybe it's a point now where they don't necessarily need residential. We can move them into IOP. Those are kind of the caveats when we talk about inpatient and residential, but we do have those added now. So clearly, take a look and see how your program, if that makes sense. And kind of in closing, I just want to talk real quick about why is this focus on MAT? What is the medication-assisted treatment? Why are we doing this? Why is it important? And what I can share with you is these are kind of the outcomes, right? So when we look at medication-assisted treatment and the research that comes out from it, these are the outcomes. So we've got reduced substance use, we've got improved treatment, we've got improved functioning, lower risk of overdose, reduced criminal activity, reduced risky behavior, better employment, and cost savings. All but that last one is really a quality of life issue, right? So what we've done by providing this is we've got a better chance of improving that individual's quality of life. And that's kind of really what this is about. We always try to go in that direction. At least when I was doing some clinical work, that was always my goal. How do I give a better quality of life? How do we work through this stuff so you have a better quality of life? And it's interesting too, and I'll just say that part of this grant requires that we don't put any kind of timeline on how long they're on the medication-assisted treatment. That's between the doctor and the individual client on how they want to do this. And if you think about it, I guess I was thinking about this morning, if it's a quality of life issue, is it reasonable for me to say, I'll give you a quality of life for a year, but then we're going to reduce that? So, looking at that arbitrary kind of timeline that sometimes a program can put how long somebody's going to be on MAT, I would argue and ask you to think about, is that reducing that person's potential quality of life? And I'm not here to say that everybody's got to be on this for the rest of their life. Again, I think there's a point in time for a client and a doc to talk about when they're getting ready to move. And I think in a clinical perspective, my role is how do I prepare them so at some point if they want to get off, that we've set them up to be able to do that. So I would just challenge you guys to think about that and where you're at with your program, and to really think about how we move forward doing this. And lastly, I'll to kind of talk about real quickly the NALOXONE program. Again, Amanda's doing some great work with this, and basically it's overdose prevention training, and she's distributing overdose kits. So you guys are all eligible to have that training, and you're all eligible to receive those kits. So you'll need to work through Amanda, who basically pounds the state 24/7, it seems like, doing this stuff. We've got 52 providers currently enrolled. They include treatment providers, harm reduction organizations, homeless services, hospital emergency departments, and we've actually also working with FDLE to make sure that law enforcement actually has access to these. So in closing, I just want to kind of reiterate what Mark and John had talked about, and that this is a change in the way that we're thinking. And for those of you that are the big book people, right? This is in the back of the big book, and this is the Herbert Spencer quote that's in the Spiritual Experience, and it's that contempt prior to investigation, and that I would challenge you guys to look at. Do you do that? Because I know that I do. And I know that I cut my teeth on abstinence-based programs. And so I had to really go back and take it and reevaluate what the information said, what the research was telling me. And I had to make a shift in my thinking to be able to do that. And I clearly had some contempt prior to investigation. So anyway, I appreciate you all allowing me to kind of ramble on. Here's a little bit of information if you need to contact me or Amanda. Please feel free. And you guys have an awesome rest of the day.